hopefully, if Dr. Frank Scott is still with us and present after that amazing relaxation exercise, I'll ask him to share his screen next. We are excited to have Dr. Frank Scott, one of our inflammatory bowel disease experts, here to present on emerging therapeutics in inflammatory bowel disease. So slight change in gears here. But Dr. Scott, thank you so much for walking us through what's the latest and greatest in IBD.
I am entirely too relaxed right now to give this talk. That was awesome. So thank you so much, Swati, and thank you to the other organizers, Dr. Ahmad, Dr. Wyman, for the opportunity to present today. Can you guys see my screen at this point?
Yes, perfectly.
Okay, great. And you're seeing the slide view. Perfect. Okay. So I'm going to be speaking about the emerging therapeutic approaches in inflammatory bowel disease and what is ready for prime time, what sort of is on the horizon for us. These are my disclosures. None of the products that I'll be talking about today are from any of the companies that are listed here. Three main core pieces here that I thought we could discuss. The first would be how we can modify our current therapy utilization to maximize potential benefit per the recent STRIDE recommendations. Then we'll take a deep dive into some newer therapies that are on the horizon, primarily focusing around the JAK-STAT pathway. And for those that aren't that familiar, a brief refresher or introduction to what that is. And then switch gears to some therapies on the horizon with regards to diet and some exciting information that we may be able to apply even today or in the near future with regards to diet modification in inflammatory bowel disease. So let's kick it off with how we can modify our current therapies. This figure here is from the recent STRIDE 2 guidance document that was published by the IO-IBD in gastroenterology. It really highlights the fact that, while we have a burgeoning armamentarium of drugs to use in inflammatory bowel disease, we are still only limited at this point by 5 to 6 agents in each, in both Crohn's and UC, and there may be some slight differences between what's approved for each, but we really should be, while we're awaiting these newer classes and newer agents to come to market, doing the best we can to maximize these therapies and really squeeze any potential benefit that we can out of them. And there are some ways that we can do this. And one of the primary modalities for maximizing the therapeutic benefit of these medications is through treat to target based care. This is a basic schematic from the STRIDE 2 guidance document. Essentially, when we have a patient who presents to us with symptoms, we should confirm that their symptoms are being driven by active inflammatory bowel disease and then initiate an appropriate therapy. This should be followed by a follow-up in 3 to 4 months wherein we assess that they've had symptomatic response or symptomatic remission, and importantly, that their biochemical markers, which we should measure at baseline, have normalized. This is an important addition to how we should conduct treat to target from what was previously published back in 2015, which focused on very important patient-reported outcomes, but noted that CRP and fecal calprotectin, which are the two main markers that we should be using for inflammation, were not quite ready for prime time. But now these data clearly suggest that we should be using them. And then 6 to 9 months after medication initiation, we should be considering structural assessment via endoscopic evaluation and repeat symptom evaluation and ensure that patients are feeling well enough to return to their normal quality of life. There are strong data to support this approach. This is data from the CALM trial, which was published in 2018 by Jean-Fred Colombel, looked at individuals starting adalimumab and randomized them to either clinical management, wherein we just evaluate patients based on symptoms on a Q to 3 to 4 month basis, versus symptomatic management plus repeated serial biochemical marker evaluation in the form of CRP and CalPro. This panel to the left here, A, is mucosal healing, which many of you know is almost unattainable for some of our patients, the hardest clinical endpoint that we can strive for. And there was a clear difference in the percentage of patients that achieved mucosal healing in the tight control group compared to the clinical management group. This was not just endoscopic improvement over either. Patients had significant symptomatic improvement as well over time in the tight control group in terms of steroid-free clinical remission. So how do we operationalize this? The Strive image that I showed sort of helps, but I also like to demonstrate this algorithm here just to conceptually wrap our heads around it, how we can apply this in clinical practice. Step one is always symptom evaluation and confirmation of inflammation. We do not want to be dose escalating our anti-TNFs, our immunomodulators, our anti-IL-12/23s in the setting of diarrhea with normal inflammatory markers and no endoscopic evaluation, no endoscopic evidence of disease. Once we've confirmed active inflammation, then we modify or initiate a new therapy. There is a 3-month follow-up. We reassess their symptoms and repeat their inflammatory markers. And I know that patients don't love submitting fecal calprotectins, but it's really important that we emphasize to them just why in our clinic visits when we're starting these medications, it's so important that they have this follow-up. Then, if they're doing well, this is followed by a mucosal assessment or structural evaluation. This is really driven by where their disease is. If this is ulcerative colitis, a flex sig is great. If it's ileal Crohn's disease, a colonoscopy may be required. If it's more proximal disease, then an enterography or capsule may be the appropriate modality. And if at any point symptoms, inflammatory markers, or a mucosal assessment demonstrate active disease, we modify the treatment plan, either dose modification of the current therapy or considering moving to another therapy and repeating this cycle. And as demonstrated by CALM, this is really the best way we can maximize the therapies that we do have. But what about therapies that are coming? Are there additional therapeutic approaches that we either have very limited options for or are completely new to us? And the answer to that is yes, there definitely are. And most of these rely on or influence the JAK-STAT pathway. That Janus kinase inhibitors come in 2 forms. One are the oral agents, which you may be familiar with, Xeljanz or tofacitinib, which we'll talk about in more detail. But this actually is where ustekinumab's mechanism of action is as well, or Stelara, which inhibits IL-12 and 23, which downstream affects the same pathways as tofacitinib, very different pathway from what the anti-TNFs typically influence, which is NF-kappa beta. For those that aren't familiar with the JAK-STAT pathway, this is a very complicated schematic, which I won't go through in incredible detail, but wanted to introduce the concept to you. JAKs are transmembrane proteins that bind in heterodimers that are then receptors for over 50 different cytokines that lymphocytes use to communicate to each other. You can see here IL-12/23 is the sort of binding receptor for ustekinumab, and influences the JAK2 pathway. We have different inhibitors now for several of these JAKs, and some of these JAKs inhibitors affect both proteins. For instance, JAK1 and 3 is the target of tofacitinib, whereas some newer agents focus on just JAK1. Going back to the IL-12 and 23 binding, however, are a couple of new agents that should be approved in the coming year or two. As I mentioned, ustekinumab affects the P40 common subunit for both interleukin-12 and interleukin-23's binding domain. And this influences via interleukin-12 Th1 helper cells and inhibits their proliferation, differentiation. Whereas the IL-23 side of things affects Th17 cells, which is a slightly different type of immunomodulatory T helper cell. Newer agents that I'm about to discuss don't target the common P40 subunit, but instead target this P19 unit, which means they're selective and just affect IL-23, leaving IL-12 and subsequently their influence on Th1 alone. Mirikizumab is one of the first agents that is likely to come to market. We're now sort of at the phase 2 to phase 3 data sort of era for mirikizumab. These are phase 2 data from the Serenity trial here, where individuals were induced via IV formulation of mirikizumab and then received subcutaneous dosing. And you can see here that there were significant clinical remission and response and endoscopic improvement signals for this drug. And over long-term follow-up, it maintained response and remission and mucosal healing fairly well. And this is an ulcerative colitis here. What's really fascinating about this mechanism of action, and I don't have a slide here to show it because it was just at DDW this past spring and it's not published yet, is that these mechanisms appear to be agnostic to prior therapy exposure. This would be one of the first agents that we have that is as effective in patients who are TNF exposed as compared to those that are TNF naive. Most of our drugs, as you'll see with this, especially with the oral JAKs, do have a decremented efficacy when they're given to individuals that have failed prior biologic therapies. Risankizumab is another anti-IL-23, another IgG molecule. This is in Crohn's. And while the mirikizumab data was in UC, you can again see significant rates of response and remission here over time during induction. These are phase 2 data here. Moving on to the next class of affecting the same pathway, JAK-STAT, are our oral agents. And these are the first oral agents that we've had since steroids and immunomodulators, which is pretty exciting and awesome for our patients. The oral JAK-STAT pathway is being robustly developed. We have tofacitinib, which is approved for both for ulcerative colitis, but not Crohn's, which we'll talk about in a second, affects JAK1 and JAK3. And then we've got both filgotinib and upadacitinib, which are approaching approval. They're in various phases of phase 3 development. I know filgotinib, for instance, the phase 3 studies in Crohn's are already enrolled and closed, so we're getting close. And then several additional agents that affect different JAK profiles are in various stages of development. These are the data supporting tofacitinib from the original OCTAVE study, both induction at week 8 amongst patients overall and compared to prior TNF failure. You can see significant rates of remission and response here. Unfortunately, you do see, and this is common with most of our agents in IBD, a significant step off in efficacy when individuals have failed TNFs already. This was approved for UC in 2018. It's unfortunately not available for Crohn's disease. The Crohn's disease study was negative. There were some caveats there with regards to high rates of placebo response and high rates of normalization of biochemical markers in the placebo arm for unclear reasons. Even though there were trends to improvement on the treatment arm as well, it unfortunately was stopped after phase 2. Tofacitinib has a rapid onset of action within several days, which has prompted some people to start to assess whether or not it may be a potential option in severe ulcerative colitis in patients that are hospitalized. This is a retrospective cohort study from Michigan where individuals were randomized to receive tofacitinib 10 milligrams TID versus BID dosing versus standard of care. And there were significant reductions in the rate of colectomy in individuals who received 10 milligrams TID. This is off-label use. It should really only be used in the setting of a clinical trial right now. But these are sort of exciting data that suggests that this may be another option for our patients that are hospitalized with ulcerative colitis, for which there's really limited options besides anti-TNFs right now. With new drugs, however, come new side effect profiles. We're all pretty comfortable now with how we screen patients for biologics prior to initiating them in terms of quantiferon gold or other tuberculosis testing and HBV screening. For TOFA, however, we also need to look at lipid profiles. For reasons that aren't entirely clear, it does appear to increase LDL levels and lower HDL levels. So baseline assessment and then a repeat at 4 to 8 weeks and treatment if necessary is totally indicated. These medications are immunosuppressive. We should be looking at their white cell count, ensuring they're getting appropriate screening, particularly for non-melanoma skin cancer. Zoster signal is elevated in these patients more so than with our other biologic therapies. And if you can get patients Shingrix before you start tofacitinib, that is ideal. And then there's this interesting signal with regards to deep vein thrombosis and pulmonary embolism, derived mostly from a cohort of older patients with RA. It still requires more confirmation in the IBD patient population, but I do counsel all of my patients about signs and symptoms that they should be looking out for when starting this therapy with regards to thromboembolic events. This does appear to be a class effect. We are seeing this in some of the other studies as well for the newer agents that we'll discuss. One of these is filgotinib, again, robust clinical remission and endoscopic remission in individuals that are naive, reduced rates in those that are experienced. This isn't UC. There is Crohn's disease data for filgotinib that is promising as well. I do suspect we'll see this for Crohn's. And this is upadacitinib, another JAK1 inhibitor. Again, reasonable clinical remission and endoscopic improvement and response signals here for this drug as well. Well, let's move on to a different class of action. You guys may have recently heard about the S1P-RM class of medications. These are sphingosine 1-phosphate receptor modulators. How do these drugs work? So these drugs are more akin to trafficking inhibitors such as vedolizumab, or as opposed to direct anti-cytokine effects. Lymphocytes, when they're floating through the blood circulation, occasionally extravasate into lymphoid tissues throughout the body, and it's in those lymphoid tissues that they can be activated or redirected to areas of active inflammation. Sphingosine 1-phosphate is a protein that's expressed that helps assist in that redirection of lymphocytes to areas of activation. The lymphocytes actually sense a gradient of increasing S1P being expressed and follow that. And these receptor modulators are oral agents that block that gradient. It reduces that signal, so it results in lymphocyte sequestration. Ozanimod has good clinical remission and clinical response data with regards to induction and also with regards to remission. Ozanimod also has a unique side effect profile that we should be aware of because these lymphoid tissues are everywhere. Infection signals are real with regards to zoster. Vaccinate if you can. There is a theoretical risk of PML with this agent. Some drugs in the same class have had stronger signals for PML. There has been one UC patient that has developed PML, but there have also been a handful of patients on anti-TNFs that have developed PML and immunomodulators as well. So we should discuss this risk with our patients, but it's not high enough at this point that experts are recommending that we screen for JC virus like we do, for instance, with natalizumab. AV nodal blockade is a real risk here, and we do recommend you get a baseline EKG. Drug-induced liver injury with any new agents, we do recommend LFT monitoring. And then there's some other more significantly rare but possible adverse events, including hypertension, abnormal pulmonary function test, macular edema, Press syndrome, which is a devastating sort of neurologic condition. And these drugs are absolutely contraindicated in patients who are receiving MAOIs. So baseline screening for Ozanimod includes CBC and LFTs. You should be getting an EKG at baseline. If there are any abnormalities, particularly with regards to AV nodal abnormalities, you should get a cardiology consultation or consider another agent. Ocular assessment is really important, particularly in our patients with diabetes, uveitis, or macular edema. You should be screening for any other medications that may have nodal effects or be immunosuppressive. And you should be getting a careful history, particularly with regards to prior chickenpox exposure and vaccination status. If there's any uncertainty, just check an antibody and vaccinate in those that haven't been exposed before. So in the last couple of minutes, I just hope to move on to diet and how it may influence patients with IBD. This is more on the emerging side of things than drugs that are actually FDA approved at this time, but also very low risk. There's a lot of reasons why patients are so excited about potential dietary interventions. First, they're non-immunosuppressive. Secondly, there's a growing body of literature that suggests that diet can modify the microbiome diversity, affect epithelial barrier integrity. There are several studies that have demonstrated concerns with regards to various preservatives in food and how they may interrupt colonic mucin, which is a protective layer that reduces interface between bacteria that live in the GI tract and the mucosa itself and enterocytes. And then there may be a direct effect on dietary ligands and immune cells, and all of these may influence IBD. Unfortunately, we've got a lot of data with regards to diets that exist, not a lot of clinical trial data with regards to how well these therapies work, and that's, I think, where the ground is being broken right now. You may have heard recently about the CD elimination diet, which is a pediatric population study that randomized individuals to enteral nutrition versus enteral nutrition in the setting of a regular diet and saw similar effects. Very exciting. More recently in adults, we've had the DINE CD study, which compared the simple carbohydrate diet to the Mediterranean diet in patients with mild CD. and demonstrated that the simple carbohydrate diet, which is fairly restrictive, involves no increased intake of unprocessed meats, fruits, vegetables, and significant reduction in dairy and red meat compared to the Mediterranean diet, which is much more tolerable. It includes olive oil, fish, nuts, veggies, and reduced red or processed meats, but much more doable. This was a head-to-head trial where individuals were randomized to one versus the other. It showed very similar rates in symptom reduction. The questions still remain with regards to inflammatory marker reduction. Some patients did appreciate a reduction in their fecal calprotectin, which is a little bit specific sometimes in Crohn's disease. Did not see much of a CRP response, but for mild Crohn's, in which we don't have a ton of therapies in patients, particularly that may not have risen to the level of requiring an anti-TNF, this may be a reasonable option. And the Mediterranean diet is actually something I have advised to a few of my patients at this point, and am following them closely to see how they clinically respond and how their biochemical markers respond as well. So in summary, it's an exciting time to be managing IBD. A couple of key points that I hope you can take away. First off, using a treat to target approach is really the standard of care to maximize the benefit that we can provide to our patients with these therapies. Secondly, anti-IL-12 and 23 therapies will be expanding, in particular in relation to these anti-IL-23 specific therapies, and these may be treatment agnostic, which is super exciting. Oral JAK inhibitors with different JAK specificity are coming. I do suspect we will see JAKs for Crohn's in the next year or two. Right now, we only have tofacitinib for ulcerative colitis. S1PRMs are an exciting new class of medication. They don't require any failure of other prior treatments. They do have a fairly unique side effect profile, so it's important you familiarize yourself with this appropriate screening for both S1PRMs and JAKs. And I do think for our patients with mild IBD, dietary therapies are on the horizon as our literature expand in this space. Thanks for your time.
Thank you so much, Dr. Scott.